Hello and welcome, everyone. I would like to welcome you all on behalf of the Ohio Program for Campus Safety and Mental Health to our sixth biennial conference, Reimagining Campus Community Partnerships, Breaking Down the Silos. First, I would like to acknowledge a few partners in the room and say thank you to the many hands who helped to put this event together and make this possible. And first and foremost, let me just say this. We are so excited to be back in person after 4 years, and a lot has happened and a lot has changed over the past 4 years. So I think that actually deserves a round of applause. I don't know if you guys are awake and with me, but a lot has changed and a lot has happened in the last 4 years. So we are just so very excited and refreshed to be back in person. Let me also provide just a few housekeeping reminders. All details regarding the conference, including breakout sessions and locations, can be found in this conference brochure. I hope that you all had the opportunity to stop by and pick this brochure up. Again, all information can be contained in that. And if you are interested in claiming CEU credits, an activity code will be provided during your breakout session. And then also, if you are, I'll just say a person who may have some challenges with technology, we will have some laptops provided where you are able to actually complete your evaluation at the end of the conference. So we will have that available for you to complete your evaluation. I also would like to give a special thanks to our sponsors, PEGS Foundation, Ohio Mental Health and Addiction Services, and Timely Care. Timely Care provides complete mental and medical care for higher education. Please stop by their table to learn more information about them. And also regarding our exhibitors, we are also thankful. We have a number of exhibitors who are here on site. And so please be sure to stop by. And again, we're thankful for the abundance of resources and supports that will be provided here today for the campus community. Poster presentations. Also, please don't forget to stop by the poster presentation this afternoon in the Resnick room. Just so you know, the Resnick room is a little bit of a distance from here, but someone can provide you instructions and directions on how to get there. We do have some really great information that's been put together. And there's also an opportunity within the Resnick room to snag a photo. So if you're photogenic and you're looking sharp, and I'm looking out in the audience and we have some people looking really nice this morning. Oh, there you go. Hands up over there. I'll say this, in addition to this month being Mental Health Awareness Month, today, May 18th, is National Mental Health Action Day. So if you weren't aware of that, today is National Mental Health Action Day. And so I encourage you all to either post your conference photos or a selfie of yourself and share how you are working together and or empowering others to take action of how you are supporting someone through everyday mental health challenges. Again, there's a backdrop back there, so I encourage you all to snag a photo. Also, I'd like to thank some of our community partners, and I know we will have and do have currently representation from law enforcement. We have the Ohio Center of Excellence for Behavioral Health Prevention and Promotion, Prevention First, the Ohio Wellness Campus Collaborative, Ohio State University Higher Education Center for Alcohol and Drug Misuse Prevention and Recovery, and the Ohio Department of Higher Education. And with that being said, I would like to invite Carrie Solar to the podium to provide a few opening remarks. Carrie Solar.
Good morning. Thank you all for being here today, and a sincere congratulations on surviving and hopefully thriving in yet another academic year as it's come to a close. My name is Carrie Solar, and I'm the Director of Student Wellbeing and Sexual Violence Prevention at the Ohio Department of Higher Education. And while it's been a few years since I worked on campus, I can still readily identify with those moments where I received those after-hour phone calls with students who are in various level of crisis and needing intervention, and being able to call on folks such as yourselves to help regulate them, get them the help that they need, really made my life a lot easier, especially as I then transitioned to helping the community repair itself from whatever they may have witnessed or experienced on campus. And so I knew then, as I do now, the value of having tremendous colleagues such as yourselves who are willing to do make a difference every single day. So thank you for the work you do every day to make students or help students and your colleagues live healthier, more meaningful lives. For the past 2.5 years, our institutions here in Ohio have had access to resources to support the implementation of services and programs to increase knowledge and awareness, to remove barriers, and increase access to behavioral health resources. The funds were designated by Governor DeWine after he sat in a meeting with students and listened to them talk about the behavioral health issues they themselves were experiencing, their friends were experiencing, both prior to and in light at that time of the recent shutdown due to the global pandemic. Those voices of students were heard by him, and so he directed federal relief dollars and distributed them to institutions to address the behavioral health needs in their communities. During the same time, I had the honor to work with our friends and colleagues over at Mental Health and Addiction Services, as well as many of the campus and community partners that Jessica just mentioned, to provide additional support and resources to our institutions in order to strengthen their own community partnerships with the goal of better serving the needs in their campus community. The work that you have done and continue to do is remarkable, and it is making a difference. At the end of 2022, ODHE drafted a mental health and wellness report for the General Assembly based on information received from our 37 public institutions. The data showed a 42% increase in students seeking mental health services during the 2021-2022 academic year. The top 3 services sought by students included counseling, mental health education programs including suicide prevention, and also crisis intervention services. Institutions also reported that students were seeking connection and belonging opportunities through involvement in student clubs and organizations, and support for their general well-being through access to tutoring and recreation programs. During the same period, a 40% increase in employees seeking services such as access to EAP programs, mental health education programs, and counseling services was also reported. Now, I'm sure these numbers are of no surprise to any of you in this room, but it was the first time those numbers were collected for the General Assembly, and I believe they demonstrate there is a clear ongoing need to build upon the efforts made over the past couple of years through the additional funding that was provided. As you work to identify ways to institutionalize efforts, it is my hope that we can continue to find ways to work together. Through the ODHE Changing Campus Culture Initiative, which if you're not aware of is our statewide initiative to address gender-based violence in our campus communities, we have been promoting and educating to our institutions about community-level prevention rooted in public health principles. It's easy, and I know as a former student development professional myself, to get stuck in our office or silo, if we will, and feel that we must make everything work on our own and within our limited resources. However, we know that when we reach out and work with other student-facing offices and our external community partners, the outcome has the potential to be greater than that which we could have ever done on our own. Working with campus and community partners to infuse wellness, inclusion, trauma-informed care, and so much else into our campus prevention efforts can help further break down those barriers that limit our ability to reach students who are hurting. As you gather here today to learn from the wonderful lineup of presenters, colleagues, and professionals, it is my hope that you will find inspiration, opportunities for collaboration, and new pathways to continue your work. As I close, I know the Chancellor would want me to encourage you to reach out and share your thoughts and hopes for the ways we may work together in the future. I look forward to working with you, and thank you for having me here today.
Thank you, Carrie. My name's Ruth Samara. I'm the Executive Director of the Coordinating Centers of Excellence at NeoMed, and I'm really here just to welcome you and to tell you a little bit more about the coordinating centers and how the Ohio Program for Campus Safety and Mental Health fits and how we work together in partnership. But as I was listening to Carrie and even going back to listening to Jessica talk about how it's Mental Health Action Day, I found myself reflecting on my days as an instructor at a major state university, and then 26 years in the community trying to create partnerships with universities. And so I'm going to go a little bit off script in a minute, I think, but I promise not to take more than my allotted time. So first, you see up here on the screen the emblems for the 3 coordinating centers of excellence at NeoMed. And so maybe that's news to you. There are 3 coordinating centers of excellence at Northeast Ohio Medical University. And I'll tell you about them in order of age. The oldest of them was instituted in the year 2001. That's the Criminal Justice Coordinating Center of Excellence. That center really exists to help forge collaborative relationships in communities between multiple systems, primarily the justice system, the mental health system, and the advocacy system, including people with lived experience, in order to create better partnerships, to better serve people who are living with mental illness, who may be at risk for contact with the justice system or become involved in the criminal justice system. Then in 2009, thanks to PEG's foundation, we were able to stand up the Best Practices in Schizophrenia Treatment Center. And that center is kind of just like it sounds, in that the center helps communities, primarily community-based mental health systems, but now we're working our way into hospital systems, to implement evidence-based or promising practices to best treat people living with schizophrenia or other psychotic disorders. And we're beginning to expand on that as well. That center is key to the success of the other 2 centers, because without good practices in the community, the other 2 centers really don't have anything to lead people to, right? And then the Ohio Program for Campus Safety and Mental Health, which Jessica has introduced, tries to help communities and campuses, universities around the state, to forge collaborative relationships so that services can be put into place related to suicide prevention, mental health awareness, stigma reduction, things that can promote wellness and increase academic success for students and the people that are working with those students. So we have the luxury of those 3 centers coexisting in the same location. And like probably many of you, we operated in silos. Quite frankly, for the first several years that we were all together, we really didn't have touch points. We were stood up independently by different funders, and we got busy doing our work. And then a few years ago, we really stopped and took a little bit of inventory and realized that we had a lot that we could accomplish together. And we're still working on that. I mean, even though we're right there together, we're still working on that, because you have to be very deliberate and conscientious about those things. They have to be intentional about making partnerships. It's not just going to happen just by nature of all being good people, right? We have to stop and make plans and figure out how we can help one another. So we continue to do that. And we're trying to be a model for that, both within each of our centers and across those centers, by including in our partnerships the very partners we want all of you to have in the work that you're doing, so that we are actually setting an example and can show that it works. And we're continuing. It's a work in progress, and you're continuing in it, and it's a work in progress. And here's where I'm going to go off script, and I'm not going to look at the rest of what I was going to say, because as Jessica was talking, I started thinking about when I was teaching at a state university, and I was in my office and a student walked in. And so I had been a clinician for many years in the community, but that wasn't my role at the university. And the university has rules about things, right? And we didn't have a lot of services, and there wasn't a lot of coordination. And a student walked in, and he was doing a lot of shifting back and forth, and his gait was funny. And this was pre-pandemic, and he was wearing a mask, and he started to tell me a variety of stories that didn't connect and didn't make sense. And so the clinician in me started thinking, what am I looking at here? But then the instructor in me started thinking, what do I do with this? Because I'm not the clinician here. And so I end up looking through my drawer and places, and the university had put out this nice sheet, this flip chart, about if this emergency, none of it answered to this emergency that I was seeing in front of me at all. So I just started making calls to the people I knew, the partners that I knew in the university, and asking questions and saying, how do I get help for this person? Because I had concerns for his mental health, his physical health. Does the family know what's going on? He clearly was not in a position to manage the course load that I looked up that he had. And so I just had a lot of concerns and started pulling people in and making a lot of noise. And we got him the help that he needed. But I remember thinking at the time, that shouldn't have been that hard. Right? It shouldn't have been that hard. And I don't think it is that hard today at that same university. I think a lot has happened, and I don't know if that particular incident helped to spur some of it along. But those are the things that we see every day on campuses that we need to be able to address. And we've got to have the right partnerships in place in order to do that. And now let me go back to the script just a second, because that does remind me, and I want to make sure I don't say it incorrectly, that if you did not get a chance to see one of the webinars, there are monthly webinars held by Campus Safety Mental Health. And earlier this year, they sponsored a webinar on campus safety that was subtitled Prevention with Purpose. And it had Officer Joe Hendry who gave the talk. And it's worth looking at on our website and viewing if you didn't get an opportunity to watch it, because he really talks about intentional partnerships and examples of who those partners need to be. And sometimes it's very unsuspecting people. And I remember that in the community, the folks that we would pull into some of our programming in our prevention services when we would do task forces, they weren't just and I don't want to say just, but the campus wellness and counseling, that's the obvious partner, right? But there are folks also doing really good research that are faculty members that have vested interests in some of the things happening in the community that we were able to tap into, who became wonderful partners in the work that we were doing. So on that note, I hope that that's how you'll use today, is to really strengthen the partnerships you've already got, get some new ideas about who some other partners may be, refresh a little bit. Hopefully, I know it's really hard taking time out of your busy schedules to do an event, but it's worth taking the time to really talk with one another and learn from one another and help each other forge forward. On that note, I'll hand it back to Jessica.
Well, thank you both, Ruth and Carrie, for providing those remarks. And Ruth, that again, we do have a number of webinars that are available for viewing on our YouTube channel. And I do encourage you all, if you get the opportunity, you have downtime, to certainly go back and take a look, as they are certainly worth reviewing. I do want to just mention again the theme of this conference, and both Ruth and Carrie touched on partnerships, right? And as planning was underway for this conference, there is a quote by Maddie Stepanek, and that quote came to mind, and really that thought too, as we think about unity, right? Campus community. And we highlighted that for a specific reason, right? But the quote states that unity is strength when there is teamwork and collaboration. Wonderful things can be achieved. And I'll repeat that one more time. Unity is strength when there is teamwork and collaboration. Wonderful things can be achieved. And so if you don't walk away with anything, just think about that quote in terms of the wonderful things that we all can walk away with when we collaborate together. What also came to mind as I reflected more on silos is that, in a sense, silos are unintentional. I don't think really any of us intend to operate, right, in silos. And so as I think about breaking down and deconstructing silos, right, and barriers, and perhaps part of that reflection also includes, and these are some questions that I began to ponder upon, but how do we become more collaborative and intentional about working together? How can we make and/or shift the narrative if there's conversations that need to happen. And to bring things to the forefront within the community conversation, because a university is a community, right? What are we learning from the community, from students, and from faculty? And for many institutions and community organizations, I mentioned earlier, the pandemic has impacted these organizations, and there has to be an intentional focus to really hear the needs and opportunities. These adjustments persist. They're not going away. It's not going back to the way things used to be. And also for many, there's a need for a continuous platform for opportunities to have continuous conversations, access to evidence-based and evidence-informed trainings. I know we talked about our webinars, and then, of course, opportunities like this conference. And then also platforms to have continuous campuses and community partnerships, right? And speaking of those partnerships, this year, we were really grateful and had the opportunity to fund 11 campus community partnerships, 2 of them new partnerships, right? And I can go on and on about the amazing work, right, that these campuses have been able to do. But I think it's better sometimes to just showcase it in a video. And so I'm going to ask Cleveland Video Company. We did ask our grantees to just put together something briefly to showcase some of the work that they're doing. And if you all wouldn't mind just briefly showcasing that, just for a few minutes, so if you'll draw your attention.
I'm Katie Harper, Executive Director of NAMI Southwest Ohio. The National Alliance on Mental Illness of Southwest Ohio serves Hamilton, Claremont, Warren, and Clinton counties. We are so grateful for the continuing support of NeoMed. For this project, we've partnered with the University of Cincinnati, Mount St. Joseph, Xavier University, Cincinnati State, and Wilmington College to provide programming to prevent suicide, promote mental health, and reduce stigma about mental illness on campus. Between the ages of 18 and 25, mental health conditions frequently manifest, and the risks are high for students who are going through major life changes, have increased responsibilities, and may be living outside their family homes for the first time. Awareness, education about available resources, and a message of hope are crucial for this vulnerable age group. Through NAMI and our own voice presentations, our stories of lived experience share the message that people with mental health conditions can still achieve their goals and help them learn to support themselves and others. With our workshop, Language Matters, we're able to engage students with hands-on experiential learning of the importance of the correct language to use when discussing mental illness. This is especially important for students in paramedical fields like occupational therapy, grad students, and for staff, these messages have more of a multiplicative effect as their language impacts so many people. A highlight for me is always reviewing the evaluations after our presentations. Reading comments like, "The NAMI presentation continues to be hands down the most favorite class of the semester," from a professor, or "Since I just started taking medication, hearing Tanner's story was so powerful," from a student. It's so gratifying in knowing that our message is truly reaching those who need it. These evaluations also allow students to let us know they'd like to volunteer, and there's almost nothing better than knowing that your message has resonated with a young adult so deeply that they're motivated to train, to be a leader, and to help reach others. Through this grant period, we've developed 30 presentations in our partner universities, and this grant has allowed us to reach almost 800 individuals so far. Thank you so much for helping us to change lives one at a time.
My name's Dan Mucci, and I'm the Mission Advancement Director for Child and Adolescent Behavioral Health. We are located in Canton, Ohio. So our grant is working with each of our collegiate partners to be on campus for 1 day, 2 hours each day. We provide them with a self-care bag. And so we work with each school to have prevention and awareness on suicide. So with our grant, the outcome has really been to reach and grow the program each year. So the first year we started, we reached about 500 people. The past couple years, we've been adding campuses to our program. This past year, we created some signs with suicide awareness message that we put on each campus. And we also created 2 virtual programs that people could attend, a QPR training and a suicide panel discussion.
Again, we're very appreciative. In all, over $400,000 in funding has been awarded to over 100 institutions of higher education and community organizations in the state of Ohio since the grant's inception. And so if you know an organization and or campus that has interest in applying, we do anticipate the application to be released sometime in July. So check back on our website as well as our social media pages. And so I have the distinct pleasure of introducing Dr. Bernice Pescosolido. She is a distinguished professor of sociology at Indiana University and is the founding director of the Indiana Consortium for Mental Health Services Research at the new IRSA Family Research Institute, which targets research in the social medical sciences. She is an elected member of both the National Academy of Medicine and the National Academy of Sciences. She is trained as a medical sociologist at Yale University, and her research focuses broadly on how social networks and culture provides insight into health, illness, and healing phenomena. Her research more specifically focuses on 4 areas: stigma, suicide, healthcare use, and healthcare systems. Her concerns have spanned local, national, and international questions and problems, primarily targeting mental illness. Her research has also been published across multiple interdisciplinary journals and has been supported by a number of institutes and organizations. She has served as the vice president of the American Sociological Association and has received several career, teaching, and mentoring awards. Ladies and gentlemen, without further ado, Dr. Bernice Pescosolido.
Am I hot now? Yeah. Okay, I don't have anything provocative to say, so that's not why I didn't have it on earlier. Yesterday I was reading the Chronicle, And the lead article in the Chronicle of Higher Education was, "We need to rethink student success." And I was like, how long have we been rethinking student success? But I will say that the one thing that's very exciting about this at this point in time is finally mental health is part of rethinking student success, because it is the last mutable form of non-retention. It's taken decades for us to get there, but we have gotten there. So today what I'm going to do is I'm going to remind you, I'm not going to introduce you to, because I'm sure most of you know these challenges, have faced these challenges more than I have, but I'm going to introduce you to, or reintroduce you to, the challenges that we face in colleges and universities regarding issues of mental health. Okay. I am then going to give you one take on it, right? This is not the answer for everything, but one take that we're using at Indiana University and at Bring Change to Mind. And then I'm going to review the science of stigma, reintroduce you to that, and then talk a little bit about how I got involved in this as a basic scientist, right? So I'm, by training, a medical sociologist, as Jessica said, and a network scientist. So how does somebody who does that work end up running a college club, which then turns into a college program? Okay, so let's start. Okay, so what are the challenges that we're facing in terms of mental health in colleges and universities? Well, there are some new facts, right? So, you know, when I started doing research on suicide a long time ago, I'm not even going to mention the decade, we didn't even start looking at suicides until age 24 because there weren't enough cases nationally to look at. But now we know that where we're seeing the rises in suicide rate are twofold. One, white men 45 to 64, particularly after retirement. But, and that's always been a high group of people who take their lives. But the new thing is that we're seeing rising suicide rates among younger age groups, right? Now, there's always been some suicide at that age, but there's the old suicide profile and the new suicide profile. The old suicide profile is really the kids who were bullied, who were excluded. That's what we sort of expected when we started looking at suicide among youth. But what we now see is that there's a new profile of suicide, and these are what I call the primo kids, right? They're particularly girls who are, you know, they're on athletic teams, they are cheerleaders, they are all in AP classes, right? 10 years ago, Steve Hinshaw at Berkeley, University of California, Berkeley, he saw this coming in a book he wrote called The Triple Bind, in which he said that girls are now facing expectations that they can meet, and they are meeting them. But the problem is that they look to the future and they say to themselves, I can't see a future in which I can sustain this level. And that's the new kind of suicide that we're seeing. So that's a relatively new fact. In addition, you know, in psychiatry, counseling, social work, we're doing a better job at recognizing how early mental health problems start. Part of the reason for this has to do with our recognition of adverse childhood events and the impact that it has on mental health as people enter puberty, right? And so it has that long arm. And so do health disparities, right? Differences that we see among different race, ethnic, social class groups, right? So social determinants of health, and even in our genetically oriented medical school in Indiana, they now talk about social determinants of health like it's a new thing, right? But I always say, well, gee, 100 years ago, my mentor wrote a book, well, it wasn't quite 100 years ago, maybe it feels like that, but he wrote a book called Social Class and Mental Illness. One of the founders of the area of social science and medicine wrote a book called Social Class and Mental Illness. We've known this for a long time. I'm excited that public health and medicine is embracing it. So that's really fairly new. And then COVID-19 and isolation, right? If there's a mental health moment, this is it. And it isn't because of all the hard work that we've been doing all these years. It's literally that COVID-19 made it clear that everybody has mental health, that everyone can have negative effects of isolation and exclusion, right? The Surgeon General, 2 weeks ago, put out a report on the effects of loneliness, right? We've known since the 1980s that loneliness has the same effect on your health as smoking 19 cigarettes a day. Okay, that's pretty dramatic. So these are things that either we've known or that we, but have not been taken up by medicine, or things that really are a new phenomenon that we're looking at. And of course, finally, Black Lives Matter, right? Focusing on the fact that social determinants of health really has differential impact on different communities. Now, these new facts come at the same time that there have always been traditional challenges that students face when they come to college or university, right? They have new living arrangements, they have new social networks are changing, they have new expectations, and they have to rise to that occasion. But also the college years bracket the years when most serious mental illnesses manifest themselves. Yes, we're diagnosing earlier, right? But in terms of the major mental illnesses, 15 to 24 is really the key ages where we see this coming up. We also now know that we have numbers attached to the mental health scale of mental health problem that we're looking for in colleges and universities. And this is due primarily to the work of Daniel Eisenberg, who was at Michigan, is now at UCLA. Project Healthy Minds. If you want to find that, just know that there are many programs called Project Healthy Minds. This is the Daniel Eisenberg one. Yeah. There you go. Okay. So we now know about 30%. And here's the thing, when I first started teaching at Indiana University, the idea was that there weren't students there with mental health problems. They weren't there. And other people would say, not only are they not here, but they shouldn't be here. Okay. But we now know that among that 30% are some of the most successful, productive, and prolific of our students. So finally, the university has woken up to the fact that we need to deal with this. And the reason we have to deal with this is that we have lost a good deal of social and individual productivity by ignoring the mental health issues that students face on college campuses. And we've also, thought about this. I think the best way, maybe you don't need to sell this to your university, but over a decade ago, I needed to convince them. And the issue of retention was really the big one. And it's still coming up in the Chronicle as of yesterday. Okay. The other thing is that the first response to a lot of this is we need more college counselors, right? But there are a couple of things here. One is that we can never have enough services on college campuses to meet the demands that we have. Not only is it greater than most colleges and universities can afford, but it's cyclical. So even if we hire double the number we had during midterms and finals or other crucial points in the semester, we will still not be able to meet the demands. And it is not the job of colleges and universities to fix the broken American mental health system, right? So we have to do something, but we have to realize what the limits are on what we can do. So today what I'm going to talk about is a way that we've sort of shaped the way that we're going to deal with these new challenges. Let me put them in context rather than talking about it here. There really are three ways that universities and colleges need to respond to mental health issues on college campuses. One is that we do have to deal with services and supports. We have to know what we have, what we can afford, what that should look like. If you need help with that at your college and university, the best place to go is the JED Foundation. What they do is not cheap, but what they do is they swoop in, and they're like a top-down organization. They swoop in, they assess what you have, they tell you what you can afford and what you need and what you can afford. I don't really know. I mean, I'm a mental health services researcher, but I don't really work out at the college level. But I know that we need to rethink that. Policies and procedures, right? This, again, is something that we need to take a hard look at. What happens to students when they are in the middle of a psychotic episode, right? What are the leave policies? Equally important, if not more important, what happens to their funding, to their fellowships, to their scholarships when they have to take a leave, right? This is, again, at the administrative level. Okay? And these are the things that I think most college administrators think about. I think more rarely is looking at culture and climate. And that's what I'm going to focus on today. Because the goal of what we've been doing as part of doing all three of these, but my part as a sociologist, is to think about making college campuses safe and stigma-free zones. In other words, the focus is both on prevention, but it's also on identification, and it's also on inclusion, right? So these are sort of the things that we're looking at. And what we're trying to do is have people think about difference in a different way, which is to think about the fact that everybody has something that they're struggling with. And if we can get students, faculty, administrators, parents to think about difference and what makes them feel different, then we can develop a strategy to deal with that. Because simply difference devalued, when you take something that makes you different and you mark it as something that makes you less than fully human, that's what stigma is. So confronting that stigma is our focus. And so not only do we focus on mental health status, but we focus on race, ethnicity, non-neurotypicality of all sorts, first-gen LGBTQ, because in the area of stigma, we talk about the double hit, right? If you have a mental health problem and something else. People have called it many things: layered stigma, compound stigma. There are many ways that people complex stigma, but that is something that we need to think about. What is the multiplicative effect of having many statuses that are challenging? Okay. All right. So let me remind you a little bit about the science. Okay. When you talk about stigma, you have to talk about Irving Goffman, right? He, in the 1960s, spent a year in the largest federal, St. Elizabeth's Hospital in Washington, D.C., the largest federal psychiatric hospital, at its peak had over 7,000 patients there. He spent a year trying to understand what was going on in terms of treatment. And as a result of that, he also wrote this book where he talks about stigma more generally. So if you want to know about stigma of mental health, it's in this book. But if you want to know about it specifically in terms of mental illness, then The Asylum is the book that he wrote on that. But what he did is he gave us really a classic definition, is that that stigma is really the mark. And what that mark does is that it changes you from a person who's seen as whole to being a person who is tainted and discounted, and the person is seen as less than fully human. There are a number of types of stigma, so you have to be very clear on what kind of stigma you're going after. I'll talk a little bit about that later. But also you have to realize that these three parts, we often see in the literature, stigma is the prejudice and discrimination associated with a particular status, okay? But these are related, because at any point we could intervene. We could change whether or not an attribute is seen as unacceptable or less than, right? Having that mark, though, trips prejudice, which is our negative attitudes, beliefs, behaviors about individuals. So, for example, you think about school shootings, you think about mass shootings. What's the first thing we hear? Okay, that person has to have a mental illness. Even my very educated friends will say, and sometimes they do have mental health problems and sometimes they don't. But in all cases, that is brought up as the specter of why there is violence in America. Okay, so that's one of the prejudicial attitudes that is attached. And in our studies, we see that. And I'll talk a little bit about that in a minute. But this also turns into attitudes about who people are willing to hire. So it not only are attitudes that people hold, but then it trips into discrimination, which are actual behaviors that isolate people, exclude them, prohibit them from having the same life chances, life opportunities that other people have. Okay. Now, if you want a summary, the quickest summary, if you need to get up to speed on stigma, is a National Academy of Sciences report in 2016. It's a little dated in that there's been some new stuff on stigma that everybody's been working on. But this is a really good summary of everything that we knew about stigma up till that point, right? There haven't been cataclysmic changes. There are some updates, but this really does, this comes right from that report. And what it does is it provides you with a guide that tells you about the terms that people use in the literature, the different types of stigma, right? So structural, if you're hitting structural stigma, you're hitting those policies and procedures that make it very difficult for students to return to college when they have a mental health episode. Public, that's the climate and culture, right? And people often say, well, who cares about the climate and culture? There is research that shows that people who live in different countries where the cultural climate is different have different reports of discrimination. If you live in a culture and climate that is highly stigmatized in terms of public stigma, those people report that they have more episodes of discrimination that they experience. And then self-stigma, which is what they internally absorb in terms of having the mark and then saying, yes, maybe I can't ever get married. Maybe I can't hold a job, right? So all three of these things are things that we can attack. But we have to know which ones we're going to attack in order to know what the targets are, in order to know what kind of interventions that we want to do. And again, I'm giving you a general framework, but we're going to focus on one specific issue. So why does stigma matter? What does the science tell us? Well, the first thing it tells us is that it has a huge effect. It partially explains why people don't recognize mental health problems. It explains why people don't seek help, why we have limited treatment options. And, it helps explain non-retention. And I think the limited treatment options is important because if you look at the prevalence of mental health problems in the United States, and you look at the prevalence of cancer, and you look at the prevalence of heart disease, you see a gross disparity between the prevalence of mental illness and the amount of resources that go into treatment of mental illness compared to heart disease and cancer, right? 1 in 4 lifetime, right? See that 1 in 4 all the time, 1 in 4 Americans? No. 1 in 4 Americans sometime in their life will have a mental health issue. Does that mean they're going to develop schizophrenia? No. But if I just take my example, and I do this work, and my husband passed away about 8 years ago, and I didn't realize until about 2 years into that I probably was clinically depressed. I do this work, and I didn't recognize it. So this power, this recognition thing is really important in terms of, what you do, and in terms of thinking about, where you can go for treatment. Okay, so this is what I was saying. It carries over to this mismatch between what services are available and the prevalence that has. It translates into the denial of opportunities, isolation and life expectancy. Studies in the US, Denmark, and other places show that on average, for a person who has serious and persistent mental illness, their life expectancy is anywhere from 15 to 22 years shorter on average. Okay, so this is real. Okay, and it's persistent and pernicious, right? There's some good news that I'll mention when I talk about the U.S. National Stigma Studies, but it's very hard to move that needle, right? And there are a lot of randomized clinical trials that have been done through the NIMH, National Institute of Mental Health, right? And what they find is that you can change people's attitudes in a randomized clinical trial. You go back 3 weeks later, back where it was. Right? Because it really is built into the fabric of our society. So we've got a really hard job here. And because of that, we don't really have a lot of sustainable programs that have impact and that are scalable. So that's part of what we're trying to work on. Okay, so what I'm going to be talking about today is You Bring Change to Mind, which is the university version of Bring Change to Mind, which is an organization I'll be telling you about in a little while. But the goal of this is it's a little goal in some ways to make college campuses safe and stigma-free zones. We're going to recognize different and develop the strategy around that. We are going to look broadly at having students think about what makes them different and whether or not they want to be accepted for their difference, and maybe even celebrate that difference, because what makes us unique is really part of the contribution that we have to the world. We want to address the triggers of mental health problems and solutions, not wait till students are struggling, but to sort of deal with issues of social isolation, stress, et cetera. And then I think the key here is that we want to leverage peer-to-peer. As they say in the disability community, nothing about us without us. I've seen a lot of top-down programming in terms of the mental health space. I think that's important. I think we need it. But you have to also have grassroots work. And this is what we're focusing on. We want people to be more aware of and accepting of mental health issues. Students, this generation of students, I've been teaching for a number of decades, this generation is more oriented toward doing, right? Since the millennials, they are really into social activism. And so we can leverage them now in terms of what a college campus needs to look at. And they're also tied to being alone together. You know, like you see them, they're all sitting in a group, but they're all on their phones. So there's a way that we have to think about new ways of addressing stigma in terms of social media. Okay, so how did I get involved in this? Because this was not why I went to graduate school. I'm first generation, by the way. And so I don't really know why I went to graduate school, except I was really good in college, apparently. And somebody said you should go to graduate school. I was like, okay. Like, I didn't know what else I was going to do. So, because I was first gen, I was like, what do you mean I can be a professor? Okay. All right. So this is basically the kind of work I do. I'm a network scientist. And so my cut into thinking about mental health was really trying to understand how people confront crises, right? And the crisis that I picked was the onset of health problems. This is what I was really interested in. And at the time that I was in graduate school, all these new models were being developed. You've probably heard of them: the health belief model, right? The theory of reasoned action, the socio-behavioral model, right? All of these things were being developed, and I thought they were great, and I was really interested in those. But after a while, I started thinking to myself, I don't really know anybody who gets into healthcare that way, right? So what do these models say? They have all different things that they lay out, but the underlying image in these models is literally a person, it's an individual, and the individual sits there and says, okay, I'm feeling this pain. Now, how much insurance do I have? How much do I like the healthcare system? Do I know where to go? What do I believe, right? Problem is that, especially with mental illness, which affects cognitive functioning, does that really fit how people think about getting into healthcare? And, part of this I take, again, from my own life. When I was in graduate school at one point, I had to go to New York City. And when I left New Haven, I had pricked my finger on a stone wall. No big deal, right? By the time I got to the airport, or when I got to the train, my finger was purple. By the time I got to the city, my wrist was purple, right? By the time I started going where I was going to go, my arm was purple. So what did I do? Did I go, okay, like, this is not normal, right? I don't know where to go, but this is New York City. So what did I do? Did I have healthcare insurance as a graduate student? I think probably. Well, I don't know. Don't remember. What did I do? I was in the subway. Now, this dates me, and I hate to say it, but there were still payphones in the subway at that point. So what did I do? I got on the payphone. I called my mother. And I said, Mom. And she said, excuse me, what the hell is the matter with you? Go get out of the subway, find the first medical sign that you can find, and go in there. I was like, okay. I went in. I had blood poisoning. If I didn't take my mother's advice, I would have died. They put a shot like about this big, right? So, I started thinking, well, we travel people's pathways. And as a network scientist, I started thinking, how do we understand how the social support system creates the kind of things that we do, right? And so I developed this thing called the network episode model that was about dynamics and social networks and people pathways to care. I was interested in biographical disruption and how that changed your social networks and how that then tripped into changing what you did for healthcare. But as I started doing this work, and we did a couple of large studies, and we were able to show that networks, in fact, do matter for how people respond to the onset of crises. But then I started thinking, what the heck is in those networks? And as a classically trained sociologist, where did I go? Goffman, stigma. So I started saying, well, let's study stigma. Let's put stigma into this model, right? I went into the literature. I couldn't find anything in the literature recent on stigma. The classic study, National Study of Stigma, was done in 1950 by Shirley Starr at the University of Chicago. And I couldn't find anything to update that. Well, I thought, well, it must be me, right? I must be missing something. So I called this guy at Columbia, Bruce Link, who is like, he's still doing stigma research. Goffman is like dead by this point, right? I can't call Irving Goffman. So I called Bruce Link, who's sort of the modern, guy who's really doing great stigma research. And I said, Bruce, where are the national stigma studies? He said, there aren't any. And I said, we have to change that. So Bruce and I got together and literally we went hand in hand begging people to fund a national stigma study in the United States. Why was it so hard? Here are the reasons. In 2004, as an example, the president of the American Psychiatric Association said, since we closed the long-term care facilities, the asylums in America, stigma has dissipated. I had just spent 9 months in the 2 largest psychiatric units in Indianapolis. I saw no evidence that stigma had dissipated, even in treatment. Never mind as people were leaving the hospital, right? And the people were either there was nobody waiting for them, or there were people who wanted to take advantage of them as they were leaving. So I was like, I don't know, sort of spidey sense on the back of my neck, my hair stood up. I was like, that doesn't sound right to me. Called the NIMH and said, hey, let's do a national stigma study. And they were like, no, God. They were like, no, we know stigma exists. Could you send us a small randomized clinical trial to change it? And I was like, what are the targets? And they go, stigma. I'm like, what kind of stigma? So that didn't work, right? So up until about the early 1990s, from when Goffman wrote, there was sort of a lot of research right after Goffman. And then there were arguments that happened. There were arguments between these 2 sociologists, really, is it really mental illness or is it the label, right? Is the problem their behaviors, like they act weird? Or is the problem the social label that we give them, right? This is what they were arguing about. So that research kind of ended, and there really wasn't very much. So what we did is we finally got the MacArthur Foundation to fund a module on the General Social Survey, which is the longest running monitor of American American attitudes, beliefs, and behaviors. Most of it not health, right? We've been able to do 4 national stigma studies since then. We will be going in 2024 to do a redo of the national stigma study on adult problems and also on child problems. What these studies did for us is allow us to see what the targets are and to see what are the roots of stigma. So for example, to counter what psychiatry was saying, we found in our studies that 50% of Americans endorse stigma of some type toward individuals, right? Individuals, because what we did in these studies was we had instead of saying, would you sit next to someone with a mental illness on the bus, right? We didn't do that because we wanted to know about problem recognition. So we gave them a story of somebody who would meet DSM, the Bible of Psychiatry, the DSM diagnosis, meet criteria for diagnosis of schizophrenia, major depression, alcohol dependence, and drug dependence, right? And so people would get a story of a person, and then they'd say, we'd ask them what caused that. Is it bad character? Are they lazy? Is it genetics? Is it chemical imbalance in the brain? Then we would ask them how serious it is. What do you think they should do? Would you have this person as a neighbor? And we didn't find any evidence that stigma had dissipated in the United States. More importantly, we found that the extent to which people believed let me say it this way. Most anti-stigma campaigns at that point were about, if we can just convince people that depression is a disease just like diabetes or cancer, and there would be billboards. Would you blame somebody if they had cancer? Well, we do blame people if they have cancer. What kind of cancers do we blame people for? Lung cancer, right? That's not the only one. There are a lot of other ones, right? Well, it turns out that we were able to show that whether or not you believe in the science base of mental illness or whether or not you believe in the moral base was absolutely unconnected to whether or not you rejected the people in these stories. So one of the things that I think the U.S. National Stigma Studies was able to do was to change the tagline of anti-stigma campaigns. We now know that 85% of Americans say that they believe that this is a disease. So spending money on that is not worthwhile, okay? Plus it doesn't have the effect that you would expect. Okay, so I do these national stigma studies. I'm basically a theoretical network scientist. I'm really interested in this stuff. What happens, right? I get a call one day, right? I'm sitting in my office, the phone rings, I pick it up and I hear, "Hello, is this Professor Pescosolido?" And I'm like, "Yes." And she goes, "This is Glenn Close." And I'm like, funny, yeah, who is this, right? I thought it was one of these two people who I went to graduate school with who were punking me, right? And, I said, "Sure it is. Yeah, hi, Glenn, how you doing?" And she says to me, No, this is really Glenn Close. I just read your article in the American Journal of Psychiatry. And I said, "I know, it's required reading for Glenn Close and everybody else in Hollywood," right? Make a total jerk out of myself. But she finally convinces me that she is starting this new organization called Bring Change to Mind because she's tired of going to galas and writing checks. She has a sister who was not diagnosed with serious bipolar disorder until 50. She had a nephew, son of her sister, who a schizoaffective disorder and was hospitalized and was incredibly popular in high school, got hospitalized, came back. Not one friend came back, right? So she's like, "I'm tired of this. We got to do something." And I was like, "Oh, yeah. I'm thinking like, I don't get involved in the real world here. I'm a professor. I like talk to students and things, right?" So, but she gets me because she says, because I thought she was going to say, "Oh, yeah, I want to put up billboards and do PSAs," which we know none of that stuff works, right? But she says, "I want to do it by ending stigma by starting the conversation." And I said, "Is that not sociological, right? Is that not what sociologists focus on, social interaction?" And she kind of reeled me in, right? And so I became the head, and I'm still the head, now with Steve Hinshaw from University of California, Berkeley, of the Scientific Advisory Board for Bring Change to Mind, okay? So we dug into the science. What can we learn from the science that exists about how to create change, right? And this was general for her work because they do a number of things to bring change to mind. So what we started saying is the first principle is that we have to have change with a longer time frame and with institutional buy-in, right? You have to have stigma doesn't dissipate quickly. You have to reel them in. You have to tell them a story that they can believe, and you have to reinforce it and reinforce it and reinforce it, right? Because there's the media telling you every day that everybody who's a school shooter has mental illness problems, right? Now, it looks like things have changed a little bit, but initially in the first book that was written about school shootings right after Columbine, a book called Rampage by Catherine Newman, which is a fabulous book, that only 40% of the kids involved in school shootings had a diagnosable or even, alleged mental health problem. I think things have changed a little bit. I think there's a copycat thing going on right now, but still, it doesn't matter. If the kid is different, they say, well, they have a mental health problem. So anyway, so then we started focusing on the idea of cohort replacement. And this idea came from a study, which has nothing to do with mental health, that was published in the American Journal of Sociology on the Vietnam War, right? When we think about the Vietnam War, we say, oh, it was the student strikes that got us out of Vietnam, right? Well, probably indirectly. If you look at what they showed, it wasn't that the people in Congress changed their mind. They didn't move from being hawks to being doves. What happened is the American population voted the hawks out and voted the doves in. That's cohort replacement. So what do you do at a college campus? You can't get rid of the administrators who don't care about this issue. But what you can do is think about starting with a younger cohort and taking a longer view of the future and trying to create a generation that doesn't have the same ideas that some older people might have, right? The other thing is to think about stigma as a wicked problem. This is something that comes out of the B schools. You know, it's complex, it's hard, you have to keep working on it. But also to think about it, I like to think about it as whack-a-mole. You know that game where, you know, there are these moles and then you hit one and another one bounces up and the question is how? That's what stigma is like. If you just work on one aspect of stigma, you are not going to get anything, right? Because think about this. Suppose you have a lot of things on campus where you work with students who have mental illnesses not to self-stigmatize, right? And then you send them out into a cruel college campus. What is that going to do? That's going to not only undo all the work that you've done, but it's going to decrease any trust they have in you. So you have to sort of work on the different aspects to have this go. Okay? So multiple levels from the target population to sectors of the institution, right? We've got to work at multiple levels, and it's got to be high touch. In other words, there are a lot of great resources out there online, okay? But online resources without having human contact in terms of those programs running is not going to be sustainable, okay? Target individuals and organizations when they're open to change, right? The acquired disposition model, Steve Vasey and Omar Lizardo. There are times during the life course when people are willing to look at their values, attitudes, and beliefs and rethink them. Guess what one of those times is? College, okay? So college is a good time to hit it. And then crisis-oriented policy, you know, famous political scientist Charles Lindblom said that American policy is not rational. That's probably not a surprise to many of us, right? American policy is not rational. We only change when there's a crisis. And then, even then we don't sometimes. I mean, again, look at the school shootings. We can't seem to move that at all. But if there's a crisis, we have an opening. And I always say that one of the things about one of the best things about COVID-19, if there can be a best thing about a pandemic, is that it's the mental health moment, right? It's the moment we have a limited amount of time where we have people listening to what we're saying and what we want to do. So we have to strike while the iron's hot. Okay, and use a mechanism of impact that is at the root of stigma, right? Goffman, stigma is an attribute known to others but can only materialize in and through social interaction. Focus on social interaction. Do not allow people to treat people with mental health problems badly, right? And so focus on the interaction, because people with mental illness will tell you, I don't care if you like me or not, but don't not employ me, right? Don't not date me, right? All of those other things. So focus on the interaction and try to get people to behave in ways that are not full of stigma. Okay, again, I already mentioned nothing without about us, grassroots ownership, local buy-in, and you need a lead to keep that high touch part. And then not an inoculation, but build into the routine of social life. In other words, the social fabric has to be, what's the word I want? It has to be integral, woven into the social fabric. Where do we get this idea from in terms of change? Okay, this is sometimes thought of as controversial, but okay, there's a book that was written by an IU PhD. She's now a professor at University of Wisconsin, right? Kathleen Blee. It's called Women of the Klan, okay? And the issue was, why was Indiana so Klan hot, right? During the time that the Klan was hot. And the answer was, it wasn't that people in Indiana aren't as nice as other people or that they're more racist than other people. It's the mechanism that the Klan used in Indiana that was so powerful that it built it into the fabric of Indiana. What do I mean by that? Well, what happened was the when the Klan came to Indiana, they did not announce themselves. What they did was they all became members of the Grange, right? Indiana is an agricultural state, and every farmer, every community belonged to the Grange, right? They went into the Grange, they got the trust of the people in the Grange. Once they were part of the community, they then started talking about things like protecting white womanhood, right? And what we saw was that focus and then the response of the women to that was so powerful that it really took hold in Indiana. And so that sounds bad, but it was also the women who killed off the Klan in Indiana. I mean, I hope it's 100% gone. I don't know. I don't study that. But when these guys would then go out on Friday nights and ride horses and shoot things up and do terrible things, the women said to them, wait a minute, this isn't supposed to be about you going out and getting drunk and doing horrible, horrible things. You're supposed to be home protecting me. And so the women were responsible for killing the Klan off in Indiana, right? So what does that mean? It means that sometimes, and this is really sad, but if you look at the people who've done evil, or as opposed to the people who have done good, they tend to be more effective. So can't we take their approaches and use them for good, right? And the simplest thing is, don't think about little change. Think about the fabric of the life that you're engaged in, and how do we change that fabric, okay? All right, so that's sort of the basis for what we did. So there were, when I brought this to, when working with Glenn, and they were doing PSAs and galas, and it was kind of fun to go to, we tried to convince her, okay, this isn't going to cut it. Campaigns don't really work, right? So we started telling her to sort of look young, go young with this. And so they started doing a high school program that they, what's the word? Somebody dumped it on them, literally. It was in Southern California. It was called Let's Erase Stigma. And somebody brought it to them, and the guy who founded it said, I'm moving to Nepal to go meditate on a mountain, but this is a really good program. Will you take it up? And so Steve Hinshaw, a psychiatrist from UCSF, looked at it and said, well, maybe we should do this. So at the same time, I started saying, we need to do college too. We need to do college. We need to build a pipeline through the educational system. So we piloted at IU Bloomington, You Bring Change to Mind, which is the university version. It had two parts, same larger theme as Glenn had, right? University Bring Change to Mind was about students, about action, and about having a place to belong, assessing it, and creating the next generation of leaders. And the College Toolbox was the scientific part. This was where faculty volunteered to do a 4-year study where we followed the entering class of 2015. And I think it's really important for people to talk about their failures as well as their successes. We started with a cohort of 2014. It was a total flop. I can talk about the reasons for that if we have time. Happy to talk about our failures. We restarted in 2015 with a better idea. And we then followed them for 3.5 years. And we got half of the freshman class. We had about 3,500 students participating in this program. One of the things that we did, and one of the reasons it failed, was because at the beginning, we kind of put together the program, even though we had student input. It was just like a few student leaders. There's a whole bunch of these back there, not full of all this stuff, but they had these swag bags that they got. And you notice that they're IU colors, right? One of the first things the students told us was, nobody wants to wear IU colors after freshman year. We want something that's new, that's hot, that's different. Okay, that's new, that's hot, that's different, right? And so we said, what? And they said, neon, we want neon. So we went with IU colors, with the neon colors, and started using these colors instead, right? There's start the conversation. Here's the back of the, thing that's got it. Of course, kids love swag and food, right? So that's what you have to do. So we started this. Okay, here are the principles. Start young. Get into orientation. Okay, that's why we are no longer a club, but we are now a program, because there are 400 student clubs at IU. Orientation has a rule, no clubs, okay? They wanted to do something on mental health. They liked what we were doing, but they didn't want to break the rule. So we started becoming a program. And so you'll see here the themes of why you can see this is from students, by students, that landed me in the provost's office more than once. Okay, so here's something that we now routinely do at Welcome Week, which come on, this is Ohio. It's hot when these kids show up, right? So what do? We give them popsicles at Welcome Week. A student came up with this idea, high quality tattoo, right? It says, Stigma can suck my popsicle. Not exactly what I would have put on there, but this is by students, for students. These are high quality tattoos. They last for 2 weeks. And what does this mean? For 2 weeks, we have walking billboards of first-year students. They love this. I don't really get it, but that's not the point. It doesn't matter if I get it, right? But you'll see why I end up in the provost's office on a routine basis, okay? Here's another thing. It's got to be by students, for students. In my class, I have a class of 200 freshmen. And I finally decided at some point their last assignment is going to be sort of, you know, what you were talking about in the last session, like have them do something in the real world. So they have to come up with an event. And, you know, so I've structured the class around teaching them how to use science, do science, apply science, right? And so one of the students came up with this. And so this is, we have a bus system. We have an IU bus system. I'm sure Ohio State has one too. I think maybe some of the smaller colleges may not. But anyway, this $25K that you would spend here is better than any money you could spend. Okay, this is why I ended up in the provost's office. This is Richard. This was something that was on the internet at the time when this came out. I don't remember this, but this is Richard. Richard tells his friend, this is Bill was on the web, on the internet. So they use that to do this. This is Richard. Richard tells his friend, just snap out of it when she's depressed. Richard doesn't know this is stigmatizing. Don't be a Richard. Okay, now, initially, it was not, don't be a Richard. Okay, so the provost calls me in and she says, Bernice, our buses go through the city of Bloomington. I cannot have 5-year-olds asking their mom, what's a... And I said, I get that. And so I said, but you know, this is what the students want to do. Lauren, how can we change this? So we sat there for a while and she came up with, you know, don't be a Richard. And so I said, well, I'll take it back to the students, right? What was the students' response? They were like, oh, that's even better because we'll get it, but you won't get it. And I was like, no, we would never get this. Like, so anyway, this is the best thing. And because students are recruited into the club. Have you seen the lime green bus? That's us. You know, come play with us, come help us, right? And, you know, Glenn shows up every now and then, which is cool. Okay, bait and flip. Now, notice that that's not bait and switch. That's illegal, right? But bait and flip is the idea that you have to do things that will bring the college student into the tent, right? Because if you just have a college club around mental illness, and you have things like lectures and events, who's going to go? The kids who already care about this. The kids who are already struggling. Maybe not even all the kids that are struggling will come to this, right? So that's what we call preaching to the choir. So the first thing you have to do is figure out how do you get outside the choir. And the way to do that is to come up with events that all students or any student would want to come to, and then you sneak in the mental health anti-stigma stuff, right? So these are all things that students came up with. Again, the students came up with this bring in the booty, again, okay, right? You know, double entendre on the booty part, right? And it's a scavenger hunt through campus, and you have to have a team of 5. And it was around Halloween, so we also had, in addition, a costume thing. And this is Fairly Odd Parents coming to bring in the booty, right? So they won. My favorite one was one group came and they were all dressed in animal costumes, except for one girl had a white lab coat on, right? The animal, so there was like a bear and an alligator and a tiger. But what Another reason they won was that they switched the heads. Like a scientist, mad scientist is in the lab, and so you get these. Anyway, I thought it was incredibly clever. Why did 20 groups show up? 20 groups of 5 show up for the first Bring in the Booty? Because they wanted to do a scavenger hunt? No, we offered a $1,000 prize, right? The group that won was a group that needed, it was a club that needed money for their traveling team, right? So I don't care why they come, right? You just get them in there and then you kind of switch it around. And then the club that was the lacrosse team, they just wanted to do this. So we provided them with the jerseys. And they were playing University of Illinois at the time. And the University of Illinois team decided they would do it too. So we provided things for them. Okay. Here's another principle, which is leverage what students are already doing. And then celebrate uniqueness, but always measure the impact. Because again, you want the university to be consistent in its goals. And one of the consistent things is you want them to be scientifically literate and you want them to understand how science works. Now, is this great science? It's going to be, published in JAMA? Doubt it. Right? But nonetheless, the students are required to do assessments and evaluation. This was another great, I love this one that they did, which is it was like, come to this place. We're going to teach you some Bollywood dance steps, and then we're going to feed you Indian food. Again, we had 150 kids sign up. We only had 100 spaces, right? So a lot of these things have worked out really well. Some of them were flops. One time I had 2 tickets to the Super Bowl. This was in the 2014 flop year. I had 2 tickets to the Super Bowl in Phoenix, right? Because somebody on Glenn's board was on the thing. And I was like, can I have 2 tickets? And people said, never say anything to Bernice about what you're doing because she will ask you for stuff. And I was like, yes, I will, because I do mental health and we get crumbs. So yeah, expect that. And I don't know, 250 students showed up. 2 Super Bowl tickets, plus flight, plus hotel. So I don't know what we were doing wrong that first year, but it was a disaster. Okay, evolving. So all of those things that you've seen, they all become brochures that lay out everything that students need to know to do it, like a budget, the process, the materials. It's got the scientific evaluation form in the back, so they know how to do that. And what we're doing now is we're redoing all of these. So in the back, it will have a legacy component. Because one of the things we learned from students, I didn't do this when I went to college. They want to leave a legacy. Like, I just want to get through college, right? So at the end, it will have the seal of the university with their names of the students who created that particular event. So hopefully we'll be rolling out nationally, and that means that everybody can contribute to this evolving living library. Okay, so here's some of the data that we collected. When I saw those first percentages of the levels of stigma, I thought to myself, we are in such trouble, because compared to the national, students are much less stigmatizing than the American population. Probably not surprising. But I thought to myself, we're not going to be able to change these, right? Nope. 3 years later, stigma was lower across all measures. General prejudice decreased. College specific. College specific is, what are people like? What are students like at IU? Right? As opposed to general questions about that, right? Social distance decreased over time, and we changed behavior. The number of students that were reported in people's social networks increased. Now, does this mean that students ran around and said, do you have depression? Come be in my friendship group. No, it really indicated greater disclosure, freedom to disclose, and freedom to discuss. To me, that's a behavioral change, okay? All right. The other thing we were able to show using inter-individual change was that it was directly related to the number of events that they attended that Bring Change to Mind put on. And now, because I want to leave time for questions, is that this has really sort of blossomed at IU. We had a new president come in. She came in and said, my issue is student mental health. She put together 3 task forces along those 3 dimensions that I showed at the beginning. And as a result of that, the Bring Change to Mind Club, You Bring Change to Mind Club on Bloomington, is now on all 8 campuses of Indiana universities, just having rolled out in the fall and really starting to be really moving now in the spring. We started partnering with totally by surprise, we find out that the NFL has required that all franchises have to have a philanthropic theme. The Indianapolis Colts picks Kicking the Stigma. I called them. I said, do you know? I didn't call them because, who calls the NFL? But anyway, so I was like, who's this woman? I don't know who this is. I know who this is. This is the owner of the Colts, right? I'm like, who's that woman? I do my research. Oh, IU grad. I send her an email. I said, do you know we do the U.S. National Stigma Studies down here in Bloomington? She's like, no. But now we're partnering with them. And I'm sure that everywhere there are groups that we can partner with. So that's where we are. So we're now on all 8 campuses. We are now coordinating with the high schools. Like I said, we're developing this pipeline. This number is too old. We're now in 520 high schools throughout the country. We have 4 middle school pilots going on in 2 different states. We have a new research institute that the Colts funded called the URSA Institute that was mentioned. So we're now doing joint activities with the Kicking the Stigma. The president now has a proposal to create that high-touch infrastructure so that when we roll out to other places, there will be that connection with national, because that is why the high school program is so effective, because you don't just put the materials out there, you have regional managers, and then you're connected to national, which provides you with most of the things that you need. Some funding, but also all the swag, all the guidance and leadership that you need. So we're currently in discussions with the Huntsman Mental Health Institute Grand Challenge, which is called Stop Stigma Together, which is a national thing, 180 organizations coming together. We're talking with NAMI, and we're thinking of, we've been asked to consider rolling out to the HBCUs through the Divine Nine. So that's sort of where we are at this point. Here's the most important
Hello, everyone. My name is Christine, and I'm a junior studying biology and Russian here at IU. And I'm also an aspiring doctor. If you had told me in high school that I would become a passionate advocate for mental health with a strong desire to specialize in psychiatry, I would have labeled you as misguided. But here I am to share with you my transformation and the incredible opportunities I've been afforded thanks to You Bring Change to Mind and the dedicated people behind the pilot program. As a child, one of my earliest memories were of a close relative who would lie on the couch for days on end. I never once considered that he might be sick. My family didn't talk about it. So when I came to IU, I still associated mental illness with violence and believed that those with depression should just snap out of it. However, as time went on, through my exposure to research, class projects, and other IU activities, I began to truly understand what mental illness entails. My entire attitude and perspective changed. I went from judgmental to supportive, from uneducated to understanding, but realistic as well. I've met many amazing students, faculty, and staff throughout my experience with You Bring Change to Mind. I now know that for those living with a mental illness, it is no easy feat for them to begin to share their stories. You Bring Change to Mind makes a tremendous difference in students recognizing, seeking care, and accepting that there will be times when one's mental health may be in jeopardy. To raise awareness and acceptance this year alone, we have organized a block party, run an extremely successful dinner and panel discussion regarding the TV series 13 Reasons Why, and held the 2nd annual Bring in the Booty scavenger hunt. Our events are open to everyone because everyone has something that makes them feel different or excluded at times. Through fun and trust-building events, our club has reached thousands of IU students, both with and without mental health issues. We are passionate and dedicated to changing the college climate. I know that we are at the end of our pilot study, but we are just beginning to make IU and other colleges safe and stigma-free zones. I am a living, breathing example of the good we can do and the change we can create. Together, we have started the conversation about mental illness and are reducing the stigma. With your help, I believe that we can save lives. Thank you.
Psychiatry rotation now at the IU School of Medicine. And we used to call her Machu Picchu girl because when she went to Machu Picchu one summer, she actually had this on her back. This is what she was carrying. There are a bunch of them over there. Take as many as you want. Those bags, there are also armbands. And for a select few, because I couldn't carry too many of them, I have some of these t-shirts if you're interested. I also have a sign up if you're interested in getting further information on any of the things that I talked about today. Just put your contact information and what you want to know, and we'll help you out. Jessica, turn it over to you.
Thank you again, Dr. Pescosolido, for that very, very informative and great presentation. And so now we do have a few minutes for questions and comments. I'm going to scan this side of the room, and Amber has the microphone for that side of the room. And if you have questions or comments, just raise your hand and we will come to you.
Hi, I was just wondering if you could just expand on maybe a couple of the things that you're doing in the middle and high school with that age of student.
Okay, so literally it can't be the same at all the different levels, right? So at the middle school, it is more focused on knowledge and awareness. The high school level, it's focused on a place to belong, right? But they're all student based. On the college level, it's focused on knowledge, a place to belong, but workforce development and institutional social change to create the next generation of leaders in wherever. We don't care if we don't want them. I mean, we don't want them. It would be great if they all went into mental health work, but we don't care if they go into other forms of work. We want them to carry with them the idea that mental health is important and that stigma cannot exist in any institution. So it sort of matches developmental levels, right? And all the programming, again, it's all student-based, but Bring Change to Mind National also has a living library of the events. And every fall, each of the clubs gets like $500 and gets, swag for, some stuff. Like I'm not that involved in the high school program, but yeah, sure. It's free, by the way. I know, because nobody asked me that. Like, somebody should ask me. It's free. That's the idea is to create these infrastructures that would allow any college or university to have this free of charge. There has to be institutional buy-in. I think, Gavin, you talked about this. If you do not have institutional buy-in, it's going to fail. Now, the institutional buy-in that we need is at least a half-time staffer that knows about student clubs. And I say this having been, once the science money ended for the evaluation, it took a while till we got this new president. My chief of staff and I kept this club alive, being the advisors. But quite frankly, we stink at this. And so we had been begging for a decade to get a halftime person trained in college student activities. We have one now. You've got to have that because students graduate, right? And they don't think about sustainability. They don't think about making sure that the next set of leaders are elected.
Hey, thanks for your presentation. You made a comment a couple of times. You were like, campaigns don't work.
They don't.
But it seems like what you've done is created a campaign.
It's not a campaign, it's a program. Because when I say campaign, I mean like, PSA messaging.
Okay.
Like every group that gets together, because I'm now an advisor on lots of things. And when you get a bunch of people together, the first thing they say is, let's create a PSA. But I remember long before I was involved in this, I had a discussion with the woman whose husband invented the CD. And I was like, she said, it takes about $250,000 to create a really good PSA. Takes $10 million to show it enough on the right platforms for it to make any change. So if that PSA is associated with all kinds of other things, action plans, right, sustainability, then yes, there's nothing wrong with PSAs as part of a thing, but when people say campaigns, they usually mean they're going to do a PSA. So I may have misused the word.
Yeah, I was thinking like there's a group in I don't even know where they're based, but I think they have an office in Madison called the Frameworks Institute, and they basically say like campaigns have been misguided. They use the wrong kind of data and information. They don't have concrete action steps. Anyway, and they're like working with people to make better campaigns. And it kind of seems like it's a little bit what you're trying to do is take it away from just a PSA, but
just a PSA. The other thing is, I don't know if anybody here is a medical historian, but I love medical history. The whole campaign thing came from sort of the idea of military campaigns, and I'd sort of like it to move away from that too. So for me, campaigns is it just has a lot of connotations that I'd like to, when they did the malaria campaign in Indonesia, they sprayed the roofs of all the people to get rid of the mosquitoes, where they were living. And then people didn't have any roofs because that's what was holding the roofs, the thatch roofs together, were the mosquito nests. So, I don't know, campaigns to me, it's just bad. But if it's a program that includes PSAs, I mean, how can you not include social media at this point? I mean, you have to. But they don't, the thing that I've noticed about students, and I could be wrong, I'm often wrong, is that they don't have a shared culture. Like okay, so let's go back to the days when, if you're talking about some kind of social phenomenon, you could talk about, something in Seinfeld or something in I Love Lucy or something in, I don't know, like the, different shows that have been on with different kinds of families. You could relate that. They don't know any of that, and they don't share things that they all watch. So whenever you bring an example now into the classroom, you have to show a piece of it or talk about a piece of it, because the only people that they share are super, super famous people. Other than that, the culture is really diffuse. Is that a good thing? Is it a bad thing? I don't know. That's really not my problem. What my problem is that we know that students learn from concrete to theoretical. So I need examples. And so now I can't assume examples anymore. And so that also tells me that social media has limited power. Not that I can stop Glenn from making PSAs, I can't. She just keeps making PSAs. But, it's her organization. She wants to make PSAs, but I don't think they're terribly useful. I don't think if I mentioned any of them to you, you would never have heard of any of them. There was somebody, yeah.
Good morning. Thank you for your presentation. I was just wondering, in your research or the work with students, when you think about stigma and a range of individuals of different races, religions, so it's oftentimes, it appears to be stigma and. Right?
Yes.
Stigma and homophobia, stigma and racism.
Exactly.
So how are students addressing those kind of intersectional identities?
Well, they're doing it in two ways. One, they can do whatever they want, right? They have to pass it by me so that they don't get arrested or I get in trouble anymore. But they can decide what they want to do. If they want to do a stigma and Asian hate, they can do that. The other thing is that one of the things, in terms about, I think one of the big mistakes and this is at the end of the National Academy of Sciences report, one of the big mistakes that people in the mental health sphere make is that we have so few crumbs in the area of mental health that people don't want to share. And what the National Academy report says is that we would do so much better if we all partnered together, and at least one part of our mission was to all pull in the same direction. So what the students do now is they heavily partner with La Casa, or they'll partner, like they did this one event that I thought was so cool. They did, this was a fashion show, and which sounds, so like passe. But what it was a trash fashion show where they had to make fashion out of recyclable materials. Or recycled materials, not recyclable, recycled materials. And so they partnered with the Environmental Resilience Student Club, and they asked Ashley, because they partnered together, they had enough money to bring Ashley Graham in, who was the first plus size model from America's Next Top Model. And so they also dealt with body positivity. So that one event was mental health, climate, and, eating disorders, whatever. And all the groups were there with their materials, and they had parts of the thing. So I think that's the other thing, is like, they can't do it all, right? Partnering is really where we are, which is why that Huntsman, this group at University of Utah, the Huntsman Mental Health Group, has created this Stop Stigma Together group, which is trying to bring all the anti-stigma groups together to see if we can maybe do what the National Academy suggested. I don't know if it's going to work, but I'm there to help. I'm the head of the metrics panel. Does that help?
I actually have a question.
Yep.
You talked about the first year being a challenge, right? Or I think you mentioned the term flop, right? And I think
big flop.
and I think sometimes, programs or clubs or whatnot, they're put together and we think we have just this grand ideal that students will participate. We may become discouraged or, how did you kind of rebuild the program? I know you said you would expand on it later. And so maybe if you could just
Well, the first thing we did was we stopped. We didn't say, hell or high water, we're going to do this year. We stopped and said, okay, let's think about this. And then we had now more students that we could talk to who were interested in this. So they would tell us things like, okay, so we put together this swag bag. The swag bag was for them to answer the survey, right? It wasn't just to give them a swag bag. They would get this if they answered it's a 15-minute, online survey. And so when we first put together put it together, it had, when we were saying, well, what should we get in this swag bag? And we were like, okay, well, let's put in like, pens and notepads, and the students eye roll. You've all seen the eye roll, right? So that we said, well, what do you want? And the first thing they said was, we want tank tops. I was like, oh, not only do we want tank tops, we want comfort color tank tops. Okay. And, these are cool. I actually saw a kid with one on the other day and I said, oh, cool tank top. And he goes, yeah, I got this for doing a study. I was like, okay. So they want these comfort color. These things are $8 each without the printing. So I'm like, we can't do that. But at this point, Glenn had come to give, because I told her, look, if I'm doing this stuff for you pro bono, you got to come to IU and like schmooze all the higher level administrators, because the kids don't know who she is, right? So come and schmooze with the administrators, all who fall over her, So it was like, okay, so we're sitting in this thing and I'm saying they want these comfort colors t-shirts. We can't afford them. She goes, who owns this? Who owns comfort colors? So somebody gets the number. She calls, she goes, hi, this is Glenn Close. So we got them for $2. So having that national touch as well as local touch is important because of these kinds of things. The Colts, are just, the Colts now, we have in the high school program, we have a summit every spring, and we can't afford to get a venue for, these, I think in Indiana, like 80 of the clubs are in Indiana, the high school clubs. We can't afford a venue for that. We can't afford the food for that. Colts gave them their practice facility. Off season, don't ask for anything on season. They won't even talk to you. But off season, they gave them that. I've been inside. I have been on the field in Giant Stadium in San Francisco. Why? Because Bring Change to Mind and the owner had a conversation about mental health. And so the regional summit in Northern California is at Giant Stadium. So having this high touch allows for things that no local group, no college or university can do on their own. But not surprisingly, as a sociologist, my argument is together we have power. Let me finish this one thing though. Okay, so then we said, well, what else do you want? And they said, we want fanny packs. And I said, do you also want mood rings? Right? So only old people can laugh at that. You know what I'm talking about, right? But anyway, so we have, which are actually first of all, they're sort of back in fashion. I don't know if these are, but when you think about safety, especially for women on college campuses, these are fabulous, right? Because their hands are free, et cetera, et cetera. So there are all kinds of things in here that we did not do the first year. Right? Because then when we said, what do you want? And they said things like that, we were just like, oh, nobody in my generation wants to wear a fanny pack or a tank top. Right? But they were like, yeah, that's what we want. And then they kind of said, yeah, next time, can they be like neon green and not IU colors? Like, okay, we just listened to the students. They're the ones that came up with, they were all in a twit over, the 13 Reasons Why show. And we said, well, what do you want to do about it? They said, we want to talk about it. Said, okay, well, who do you want to be there? They said, we want somebody who knows about social media. We want somebody who knows about suicide. So that's what we helped them do. We got somebody from the American Foundation for Suicide Prevention. Somebody in the media school does this kind of work. We had a student on the panel. And then, again, we offered a dinner, and they wanted to do it as a dinner. Again, we had about 150 people enroll. We could only have 100 there. So there's plenty of evidence that we can. And when they say 150, you should plan for 100, because then about 50 students never show up. You know, like it's a good intention, but then they're busy. They have a, you know, an orgo final the next day or something. So, so it's really that at the beginning we were trying to launch a program and we didn't have enough student involvement. We didn't know how to get students in the door, and we still have that problem because, again, these students are really stressed in a way that I was not stressed in college, and they also have. So one of our former presidents of the club, who's now at Harvard Medical School, he came to me and he said, I'm filling out, I don't know, they have to fill out some form that like they all apply to the same place in medical school now. Like if there's one like site or something, you all know more about this than I do. He goes, well, I said, well, this was before he was president. And I said, why don't you run for president of the You Bring Change to My Club? He goes, I can't. And I said, why? And he said, because there are 17 lines on this application under extracurriculars. And I said, George, this does not mean you have to have 17 activities. He says, it doesn't, right? He was first gen African-American. He was like me when I was in college. I didn't know. I said, look, the way that you get a good letter and what medical schools are looking for is that you stuck with something and you became a leader, right? I had an ulterior motive there, but anyway, but that's true. Like, you know, if you get something with 17 extracurricular activities on it, are you going to believe it? I mean, this guy would have done it because he's unbelievable. But, you know, those are the kinds of things that actually students join the club for, is to have sort of more connection with faculty as well. So anyway, you have to listen to the students, and maybe the first year's a little rough going.
Thank you so much. I appreciate that. Let's give Dr. Pescosolido another round of applause.
Thank you.